Today we're going to go over heart failure and LVADs, a bridge for a broken heart. So we're going to start off with some questions, and you can just think about them. You don't have to answer them right now, but the purpose of these questions is by the end of the lecture, hopefully everyone will be able to answer them. So a class 4 heart failure patient has a mortality rate similar to an aggressive cancer, for example, like a pancreatic cancer. Is that true or false? The number of heart transplantations is limited by a shortage of suitable recipients. This is a kind of a question here. All right, we have a 68-year-old man who looks younger than his stated age. He's been referred to you. He has non-ischemic cardiomyopathy. His EF is around 15%. He's had a stroke in the past and is confined to a wheelchair. His memory is very poor, just a short-term deficit. But he has a very dedicated wife. She's with him 24 hours a day, 7 days a week. Currently, he's on an inotrope. He's on milrinone. He has class 4 heart failure symptoms. What do you recommend? A, list patient as soon as possible, status 1B on the transplant list. An LVAD as destination therapy. A palliative care consult or a short-term support device. Make him get better and then move on to a durable long-term device. Interpret the hemodynamics. So you have a patient. Only thing you have is hemodynamics, basically. You don't have a lot of information, but somehow you just get these hemodynamics. And it's a heart failure patient, so you may want to ask some questions about the history, about the labs, because hemodynamics mean nothing if you don't know the physical exam, the history, and the labs. So by the end of this lecture, you guys already know hemodynamics, but I'm going to do it from more of a cardiology perspective, from a heart failure perspective. RV failure, LV failure, does this patient have pulmonary hypertension? Is he volume overloaded? And how will you treat these hemodynamics? Lastly, after an LVAD surgery, the patient will not be able to do one of the following: exercise, swim, travel, or self-care. What is the average 1-year survival of an LVAD patient? And we're putting both bridge to transplantation and destination therapy patients together. 69%, 81%, or 91%. So by the end of this lecture, we should really be able to know these answers. So there's about 5.8 million Americans that are living with heart failure. And as you guys all know, heart failure hospitalization is associated with increased mortality. The first hospitalization over the year, they have a 34% mortality. By the time they get to their 4th hospitalization, their mortality is around 60%. So every time these patients come in, bad sign. It's important to note the stages in the evolution of heart failure. We have 4 stages, stage A, B, C, and D. A are patients who have risk factors for heart disease, but they have no heart failure or symptoms. So they may have hypertension, diabetes, they may have hypercholesterolemia, but they haven't developed any heart failure as far as structurally. Your stage B are your asymptomatic LV dysfunction patients. They have a weak heart, but they just don't know about it yet. C's are your prior occurrent symptoms of heart failure, and your D are your refractory heart failure. These are the patients that we're going to really talk about today. So it's important to know your staging in heart failure because that tells you when you're supposed to add medications. So A, of course, you would make sure you do risk factor modifications. So treat the diabetes, treat the hypertension. B is when you add on your ACE and your beta blocker. C, that's when you add on all the meds: ACE, beta blocker, diuretic, aldosterone antagonist, hydralazine, isodil, and your devices. And D is where we're going to stick to. That's your transplants, your VADs, your inotropes, and palliative care. Staging is different than NYHA class, as you guys all know. Class 1, no limitations. Class 4, they're pretty much short of breath at rest, can't do just normal activity. In heart failure, there is a continuum of treatment. We know that patients have an improved outcome if they use ACE, ARB, or Entresto. They have a better survival, decreased hospitalizations, beta blockers, aldosterone antagonists. We also know that CRT and AICDs are useful. In African American population, it was found that hydralazine isosorbide dinitrate reduces morbidity and mortality. Digoxin reduces hospitalizations, but it does not make our patients live longer. You guys are familiar with this. So let's talk about the most advanced heart failure patients. So you have about 5.8 million Americans who have heart failure. 40% will have heart failure with preserved EF. So we're going to take them out of the equation. So you're left with about 3.5 million patients. 5% of those patients will have class 4 heart failure symptoms. So you're left with 174,000. We're going to be able to transplant about 2,100 per year. So what kind of treatment options do we have available for this 171,000 patients left? Mortality with class 4 heart failure patients is bad. So once they get class 4 symptoms and they're compliant, they're taking their meds, their mortality rate is similar to an aggressive cancer. And I think that's a very important point, because these patients who come in who've had long-standing heart failure and they have another comorbid illness on top of it, and they were sick to start with, these patients are not going to do well. And I think we have to start becoming a little bit more comfortable with understanding that. So if you look at this slide, it was comparing class 4 heart failure patient with pancreatic patients for the year, and as you can see, it's very close as far as mortality. So today we want to identify heart failure patients who are at risk for mortality, because those are the patients that we're going to take care of, the advanced heart failure service. What are the treatment options available, and interpreting hemodynamics from a cardiology perspective. So the first thing you have to determine is who's really sick. So when they come in, everyone looks the same when they have heart failure, but there's some differences between these patients. So there's basic questions that you ask your class 4 heart failure patients. You want to ask yourself, how do they look? Typically, they may be cachexic. And you have to, cachectic, when we think about that, they could be overweight, but they have a lot of muscle wasting. So that's a sign that things are not going that well. How do they feel? You ask them that. Most heart failure patients will say that they feel great. Okay, they always say they never have any problems. But when you ask them what do, they cannot do basic activities of daily living. They have problems taking their showers. They have problems cooking their breakfast. They have problems just doing very basic activity. So that question of what they do, if they spend time watching TV the whole time, that patient's pretty sick. And another question you have to ask is the EF helpful? Does the EF tell you how your patient's going to feel? No, so it doesn't. EF has nothing to do with the functional capacity or how functional your patient is. EF only is associated with mortality. So this is a trial that was done in the early 90s, and basically these are patients who had MIs. Patients who have the lower EFs have higher mortality, and that's been shown in our literature throughout. So who is at high risk of dying in a year? Well, patients who have recurrent hospitalizations and are on standard oral therapy, taking their meds, have their device therapies, patients with hyponatremia, elevated BNP, troponins, patients who have a lot of arrhythmias. That's a sign that their mortality is higher. Kidney problems is an issue, as well as requiring high diuretic doses to be diuresed. Are patients with low blood pressures. So either they're optimized on their heart failure medications, or you're not able to get them on their heart failure medications. That is a clue that this patient is end-staged. Low BMI, and we know that in our heart failure literature, heavier heart failure patients actually have a better survival. So it's called the obesity paradox. They actually do much better. So the skinny ones don't do as well. EF is a problem if the heart's real dilated and if they have evidence of diastolic dysfunction on their echocardiogram. So these are all indicators of mortality. We have different prognostic models to try to help us predict survival, but they're kind of difficult to use in our patient population. We have the heart failure survival score, which we put in several variables and to determine what their risk is, low, medium, or high. If they're high risk, these are the patients that we'll consider for transplantation. We have the Seattle heart failure model, which we can use. We put in several variables, and then we put in our intervention. Let's say the patient's not on an ACE. You add your ACE and then see what their 1 year, 2 year, 5 year survival is post-intervention. The problem with this model is that it doesn't account for patients who are really, really sick. This is like the walkie-talkie class 2, 3 patient, but not the class 4, barely make it in the hospital every other week. And we also have the HF action risk model. Still not very useful in the very sick patients. This is data from our ADHERE registry that looked at patients who were admitted with heart failure and followed them over the course of several years. And what they found is that if their creatinine is high, BUN is high, blood pressure is low, outcome is bad. So they can have up to 22% chance of dying as an inpatient if they meet some certain of these criteria. So we do have options for our patients. We have our standard medical therapy, which all of you guys are familiar with. We have, the BiV pacer to help with synchronizing the ventricles. If they have valvular issues, we can do valve repairs. And we have investigational drugs. But once all these treatment options have been tried and, it's not successful, what do we have left? So we have hospice. So the majority of the patients will go hospice that are heart failure patients. And I think that's I just can't tell you how important of a point. We have to learn when to stop. Just because we have things, people should not have it. So, and we'll talk about the numbers, but we're not transplanting a lot of patients. We're not VADing a lot of patients. But we still have that 172,000 patients left over. So the majority of the patients will go hospice, and we as physicians have to be comfortable with that. We have VADs, either destination therapy or bridge to transplantation. We have inotropes, and we have transplant. So let's talk about inotropes. Inotropes are terrible. Inotropes are okay if there's some kind of acute accident and, the cardiac function is down, or maybe they were septic. But in these end-stage heart failure patients, inotropes has a very dismal outcome. So when we put our patients on inotropes when they come in, creatinine's high and they're, in cardiogenic shock, and we put them on inotropes for ourselves so we can get them out of the hospital because we feel bad, they don't live long. Their mean survival is around 3 months, and it has a lot of problems. They get infected. They have arrhythmias because there's a PICC line that the Millerno will go through. They have arrhythmias, and then they have a false sense of that they're going to live longer. So I think when we use inotropes in these patients, when we can't get them off of, we're trying to send them home, they need to see palliative care, and that we need to have a conversation that your survival is about 3 months. If you don't, you'll pay for it later. And I know personally, so. How about transplant? Well, we're limited by available donor hearts. And this has been going on for decades. For the last 3 or 4 decades, this is the registry from the International Society in Heart and Lung Transplant. And you can see the red line is about 2,500 transplants done in North America. We can't even get above that line for 3 decades. So transplant is not going to be an option for these patients. We have to remember that the standard of care is transplant. If you are asked which one you want, we don't want any of them. But if we are asked, transplant is the gold standard. Median survival is around 13 years. They do very well. And I worked at Children's last year. These kids would live 24, 25 years. But they get them the transplant when they're like 2, though. But they live a long time. So transplant is definitely, by far, hands down, the preferred therapy. Let's move into indications for mechanical support. So we know we need something because transplants is not going to do it. Medications are not good enough. So we have different indications for mechanical support. We have bridge to myocardial recovery or decision. That's person comes in crashing and burning. You don't know them. You know they're in heart failure. You know they're dying. But you don't know what's going on. They may be really young, or you just don't know much about them. This is when you use your short-term devices to determine what's the next step. Is the next step death? Is the next step to a durable VAD, or is the next step to a transplant? Bridge to transplantation, typically I'm talking about a durable device. When I say durable, it means they can go home with it, they can plug into the wall, they have batteries. It's a device that they can get out of the hospital. And they will use this device prior to getting their heart transplant. The reason why this is a very important strategy to have is because most patients will have to wait 14 to 16 months to get a heart transplant. And we saw from the earlier data that they die. So we need something that they'll live for that 14 or 16 months. And the LVAD has been, it's worked. These patients live and they get robust and they get strong. Destination therapy means that they will have this device for the rest of their life. They're not a candidate for transplant. Maybe they're too old. Maybe they have had a cancer. Maybe they just don't want a transplant. But this is destination therapy is another strategy that we use, mechanical support. The purpose of a VAD, we want to restore hemodynamics. We want good end organ perfusion. That is what the LVAD is doing. Making sure the kidneys get blood, the liver, the brain, whatever, every place gets blood. But when we talk about LVADs, and we need to understand where the patient is before we really move into VADs. So I'm sure you guys are very familiar with how we look at our patients in the CICU. So we look at our heart failure patients in quadrants. We want to know if they're warm or dry. So warm is their perfusion state. If they're warm, that means their cardiac output is good. If they're dry, that means hopefully their wedge is normal and not too low, okay? Warm, they can be warm and wet, meaning that their wedge is going to be high, however, they're perfusing adequately. Cold and dry is the worst place to be. It has the highest mortality. They're not perfusing well, cardiac index is down, and they may have a normal wedge or even a low wedge. And cold and wet, not perfusing well, but you can diurese them. So let's look at these hemodynamics again. So this patient's coming in with a mean pressure of 100. RA pressure is 15. PA is 62/28. Wedge is 32. Cardiac index is 1.7. Output is 4. EF is 30%. It's a non-ischemic. So let's just say you see this patient and you don't have any information. You just have his hemodynamics for some reason. I don't know. But you're given 3 questions to ask. It can be labs. It can be physical exam. It can be history. But you want these 3 questions to really count because you're really trying to answer something with these. Because this patient has a history of heart failure. We know if you have a history of heart failure, the most likely reason you came back in is because you have heart failure. Now, there may be something that precipitated the heart failure, but the most likely reason you came in is heart failure. So if you had the choice of 3 questions, make them count. Like, it doesn't matter about how many cigarettes you smoke, okay? So make these 3 questions count. He's room air. He's lazy. Oh, make this last question count.
His organ damage.
Yes! Yeah, you have to ask about perfusion. When you see numbers, an index of 1.7, that's not really that low to me, but you always ask about perfusion. Creatinine, LFTs, lactate, mental status. Is he cold on exam? So that's the kind of the questions you want to get used to asking if you're in the CICU with heart failure patients. So we're going to look at his hemodynamics. So something really good about this gentleman is that he has a pretty high mean arterial pressure. That's really good. Nice wedge. Index is low, but if you were to treat this guy, how would you do that? Diurese. And what else would you do?
Lower after load.
Yes, vasodilate. Exactly. So he does not need milrinone. Okay, let's move into where is the swan. So we use swans a lot in our CICU. You guys do too. Do you guys know where we are here? You look at basically the scale. You look at the notch. You look at the pressure. Dichrotic notch. Yes, we're in the pulmonary artery. Okay, once again, you look at the scale. You look at the EKG. You look at the A wave, the X and Y descent. RA pressure. Once again, look at the scale. All right, so it's a little higher. And then you look at systolic and diastolic. So you know there's no notch, and the diastolic pressure is pretty low. It's almost going back to baseline, so you know this is RV. Some of these things, you'll have to learn. Basically, you have to memorize what kind of know what the picture looks like, but then learn what each wave means. And this is the wedge pressure. So when we use our hemodynamics to really help us calculate, we want to make sure we know what the SVR is. If we know the SVR, we can vasodilate them, okay? If we know the PVR, that's helpful to help us know, is this real pulmonary hypertension? Is it secondary to their left-sided heart failure? But we can use DPG, TPG. There's a lot of other things we can use. But it's important to know how to use the Swan-Ganz number just overall. When we put the SWAN in our heart failure patients, there's certain hemodynamics targets we're trying to achieve. We want their wedge pressure to be less than 16. We're not going for normal wedge, 8 to 12, because these patients have larger hearts. We want their RA pressure to be less than 8. SVR less than 1200, but if we can get it, we prefer like 800, 700 if possible. Cardiac index to be greater than 2, and blood pressure, systolic blood pressure to be greater than 85. So there's several ways there's a couple ways we can increase the cardiac output. We can do that by decreasing the SVR. We can, depends on the patient, not in our heart failure patient, you don't want to give them preload, or you can give these patients inotrope therapy. So the whole goal of the Taylor therapy is we put a swan in them, we try to change their numbers with IV medication. So let's say that first guy we saw, he has a high SVR. So we put him on nitroprusside, and we put him on a diuretic. So we start that therapy off, and then what we're trying to do is convert them to oral. So as the nipride is on, we would start the ACE or the ARB or Entresto, whatever we decided, the hydralazine, the nitrates, and we would turn down the nipride as we turn up the oral medications. And we do the same thing for the IV diuretic. So we're trying to do it really quickly, and that's when we say Taylor therapy, that is what we're doing. So this is this is more hemodynamics. This guy has blood pressure of 140/80. His RA pressure is 27, PA 62/28 with the mean of 39. Wedge pressure is 33. Cardiac index is 1.4, and his EF is 55%. That's all you have. Do you want to ask anything about this guy?
Organ damage.
Okay, what do you want to, creatinine is baseline.
LVADs.
Baseline,
Lactate.
1. Yep, it's kind of the same treatment as the last guy. But let's talk about RV failure, LV failure, pulmonary hypertension. So when we talk about RV failure, looking at hemodynamics in the heart failure population, we look to see if the CVP is greater than the wedge. If the CVP is greater than the wedge, that's an indicator that this patient may have RV failure. We also look at the CVP to wedge ratio. There's been studies done in heart failure literature that show us that if the CVP to wedge ratio is greater than 0.63, this patient is more likely to have RV failure. And we also look to see if the CVP is greater than 20. So this patient has signs that the RV might not be that great. You know, the ratio is a little high. The RA is greater than 20. But you really need to diurese them first and see what happens. But this is not a good sign. This is not a good sign. We know this patient has LV failure. He has a high wedge. His EF is low. Oh, his EF is normal. Whoa, okay, let's talk about this. So he has a normal EF. Cardiac index is low. As far as pulmonary hypertension, we can use the mean PA minus the mean wedge. Okay, and we can divide that by his cardiac output. I don't think he's going to have pulmonary hypertension. And we can use the DPG as well as the TPG. So this patient, when you see a high wedge in the setting of a normal EF with a low index, what does these hemodynamics kind of look like to you? He has a normal EF. It's like, yeah, it's heart failure with preserved EF. Yeah, so this is the treatment for this is bring down the blood pressure, diurese him, try to see if you can find the cause. You know, is something contributing to his heart failure with preserved EF? Another one, we have a patient with a low blood pressure. He's tachycardic. RA pressure is 4. Wedge is 9. Cardiac index is 1.3. He's very sick. So if you were to use those, cold, wet, warm, how would you describe his hemodynamics? Right? They have the worst outcome, right? All right. So what is this called? What do you want? 3 questions for him? 3 questions? Creatinine is 3 times. It's pretty bad. I don't know what it is, but it's going to be bad. It's a couple times normal. He's cold on exam.
Lactate.
It's high. So this is cardiogenic. Yes. So it's cardiogenic shock. We gave him a little fluids because his wedge is kind of low for a heart failure patient. He has a wedge of 9. We like their wedges to be around 15, 16. So he's going to be more arrhythmogenic. So we gave him some fluid, about 250, added some milrinone, and he became hypotensive and had VTAC anyway. We repeated his lactate. It was up to 8. His creatinine went to 2.5 times normal. What are your next steps with this guy? Oh, yeah. Good job. I'm going to leave. I should just throw down my microphone. Good job. Okay. So when we talk about cardiogenic shock, it has a very high mortality. especially if they're refractory to inotropes, balloon pumps, and revascularization. In this patient population, when they come in with acute cardiogenic shock, these are not good patients for the permanent LVADs, which we're going to talk about. So we want to move into our more temporary support devices. So we want to implant temporary support devices when you really don't know the patient's neurological status, if you don't, they come in from another hospital, or if they're refractory to the inotropes, balloon pumps, or pressors. If they are in any type of end organ problems, these are the kind of patients you want to do short-term devices. You can use your devices as bridge to decision, bridge to recovery, or of course to withdrawal. Most of the patients who require a short-term device will not survive in the 80%, it's like 85%. So these patients, when we counsel with the family, they need to know that. And my population in particular, because most of them will already have heart failure. Now there's some acutes that come in, but they don't do well long-term. So we have a 46-year-old man. He presents to the outside hospital ER with severe shortness of breath and hypotension. He's intubated, rapidly requiring pressors. He's had a cardiac arrest, requiring 35 minutes of CPR. His pupils are fixed and dilated. He has another cardiac arrest during his transfer. On arrival, his blood pressure systolic is 60 to 70s. His heart rate is 140s. He's cyanotic. He's mottled. Creatinine is 3.4. The LFTs are elevated at 5,000. Lactate is 18, so he's not doing well. He's on DOPA, Epi, and Neo. Bedside echo shows severe biventricular dysfunction. He has an EF of less than 10%. All right? So what are your treatment options? Balloon pump, continue aggressive medical management. Take the patient immediately to the OR for temporary mechanical support, Impella 5.0 or Centromag or ECMO. HeartMate 2, take patient to the cath lab, percutaneous VAD, or do nothing and allow the patient to die.
5.
Huh?
5.
Yeah. Very good. So fixed and dilated CPR. Yeah, this patient, do nothing. But a lot of times we do something. Do you guys see that? Yeah. Okay. So reasons to justify temporary support: they have refractory cardiogenic shock, and they have some contraindication to permanent type of support. You know, the best thing for temporary support is just give them a couple days to see if they turn around, see if you can move them to the next higher level of support, or withdraw the support for recovery or death. So we have several short-term devices to talk about. We have ECMO, we have the tandem heart, Centromag, Impella, and balloon pumps. And everyone's quite familiar with the balloon pump. It doesn't give us a lot of cardiac output, but you know, we used this for years before we had these fancy devices, and people did quite well. You know, they did fine. They weren't losing extremities, but it worked. So we have several indications. We use it after cardiogenic shock, or after MI when a patient has cardiogenic shock. Sometimes they use it in the OR to get patients out of the OR, but typically nowadays we're kind of using more aggressive type of care. We have ECMO. It's a centrifugal pump. It can deliver up to 8 liters of support. Very reliable. Membrane oxygenator removes CO2 and oxygenates the blood, and it's very cheap, but there's a lot of complications associated with it. And you guys are familiar with the ECMO circuit, and that's what it looks at bedside. We have VV ECMO as well as VA ECMO, so it depends. You guys probably use more VV ECMO. We use VA on our side. So we have a lot of experience with the VA, but do you have a lot of patients who have pulmonary issues and lung issues? Not really. Or pulmonary issues and cardiac issues?
Usually they start with the pulmonary issue.
And they develop cardiac, yeah. They probably start with VV and get switched to VA. Does that happen a lot? Enough, a transplant. We have the Impella 2.5 and 3.5. That means it's giving us 2.5 liters per minute of flow. This is a catheter-based system implanted in the cath lab. Pretty easy device, but the problem with this device is the positioning. A lot of times these patients have a lot of hemolysis and bleeding, and if the device goes out of position, it alarms. So it's kind of it's a lot of labor intensive to take care of this device, but it does provide really good flow. And this is what the Impella looks like. We have the Impella 5.0, which will give the patient much more support, 5 liters per minute. And is performed in the OR. They have a cut down, much more support. So we use this for patients who are really not doing well. Tandem heart, we use it for acute hemodynamic support. This is placed in the cath lab too, is a centrifugal pump. Provides up to about 5 liters of support. And we use the CentriMag device. This device, it requires a sternotomy. They go to the OR. And basically, CentriMags can be used on the right or left side, so they can end up with 2 side support. It's less expensive. It's easy to implant. And we can use this for like a couple months. This device tends to be a little bit more durable. And there's articles have been written that if you don't really know the patient, whether or not they're going to do well, you get these transfers in that you're not sure if they're going to wake up. Using these short-term devices, in particular CentriMag, patients do well. So this article actually looked at 12 patients who were transferred from the outside. They implanted CentriMags in all 12. 4 of them died, but 8 of them successfully went on to HeartMate 2 devices. So that's pretty good for patients who are in straight shock. You have a 19-year-old male. He comes in with chemo-induced cardiomyopathy. His EF is around 30%. He presents with increased shortness of breath and chest pain. He's compliant with his medications. He's on Coric 12.5, lisinopril 20, aldactone 25, and Lasix 40 twice a day. Physical exam, his blood pressure is 142 over 84. JVP is around 15 centimeters. Heart is regular rate and rhythm. He has S4. He has 3 plus edema. ECG shows normal sinus rhythm. He has some LVH on EKG, the pattern. Sodium is okay. Creatinine is 1.4. LFTs, lactate are normal. His BNP is a little elevated from his baseline, and his EF is 30%. So for some reason they did a cath in this guy, a right heart cath, but they shouldn't have. So basically this guy kind of has the same pattern. And this pattern we see quite often. A lot of our patients have higher blood pressures or higher SVRs that we don't have to start inotropes on them. So when you see a low index, you shouldn't automatically do inotropes. Inotropes are deadly. People do not do well on inotropes long term. They die typically within 3 months. So we want to always use oral vasodilators or IV and switch to orals in these patients. So in that patient who was pretty much hypertensive, had a low index, high SVR, how will you treat that patient? You would want to use nipride and Lasix in someone like this. Good kidney function, young guy. He had high blood pressure that was poorly controlled. So let's move on to our other devices. So we start with drugs. And then if they don't work, we move to our devices. We balloon pump, Impella, ECMO. But those are all short term. So let's move on to our durable devices. And these are the devices we use in our chronic heart failure patients who actually are stable. They're not crashing and burning. And these are the devices we use. The landmark trial that tells us that LVADs are good was actually called the REMATCH study. It was published in 2001 in the New England Journal of Medicine. They looked at 129 patients with class 4 heart failure symptoms, randomized them to medical arm, LVAD arm. Basically, that study showed us that LVADs have an improved 1 year and 2 year survival. So that was the landmark trial that LVADs became FDA approved for destination therapy. So that trial consisted of the first generation device. It was called the HeartMate XVE. And this is the configuration of pretty much all of our devices. The inflow cannula is inserted into the LV. Here's the pump. Blood goes to the outflow cannula into the aorta. What you'll see outside of the body is this drive line, the controller, and the battery. So the patient always has to be connected to some type of power source. And this drive line, we have to always take care of it. And what happens with time, they get this tissue ingrowth, and the drive line actually becomes part of their belly, like part of their skin, if they don't have a drive line infection. But it's pretty stable. We've moved on to the second generation devices. This is the HeartMate 2. You'll see a lot of these patients around our hospital. This is a continuous flow pump. So if you check their pulse, they're not going to have a pulse. This axial flow. These patients are very functional. It's estimated that they should live around 5 to 10 years, but we have several people who are 9, 10 years out. So we're thinking that it has complications, but we're thinking that this pump is gonna do pretty well. If you examine them, they will not have a pulse, but if you do a blood pressure, you have to get that by Doppler, and the first sound you'll hear is the mean arterial pressure. This is how the pump looks. There's a rotor that spins around. It's maglev, and that's pretty much it. This is the survival curves, looking at the continuous flow LVADs, and this is for the destination arm. Their 1-year survival was around 68%. Now it's a little bit better. 1-year survival for the DT arm is around 78%, 76%. So as the clinicians get better at taking care of these patients, the survival improves. Not only do they have improved survival, but they also have improved functional status. They walk further, they have NYHA classification goes down, they feel better. So the LVAD provides support not only for survival, but also quality of life. The third generation device is called the Heartwear system. Kind of the same configuration, but you can see there's no inflow cannula. The device is intrapericardial. And the outflow cannula is still connected to the aorta, right here, drive line. And the only thing you'll see outside the body is the drive line, the controller, which controls the speed of the pump and gives the patient the alarms. The patient has to always be connected to some type of power source, either the battery supply or to the wall. So you can see this is not a good option for someone's crashing and burning, pupils fixing. This is an option for someone who's a walkie-talkie, person who's doing pretty well. Not well, but not crashing and burning, okay? Survival with this pump is around 86% 1-year survival versus the HeartMate 2 is around 85% 1-year survival. And our survival at Ford our 1-year survival is 85.4% versus Intermax, which is our national registry, is around 81.1%. So our survival is a little bit better with our LVAD program here at Ford. But the problem with this is that they are still tethered. So it doesn't matter that they have a great survival and a good quality of life. They have to always be connected to some type of power source, which is very life-limiting. They cannot get wet. They cannot have an MRI. So, some of them we don't want to fish on a small boat. That wouldn't be a good idea. They can't swim. So it can be a life-limiting type of thing. So our goal with these LVADs is we really want to obtain the maximal survival and the best quality of life. That is the goal of these LVADs. So let's go through our questions. Class 4 heart failure patients have mortality rates similar to aggressive cancers. Yes, they do. They die. The number of heart transplantations is limited by a shortage of suitable recipients. False. Suitable donors. We don't have enough donors. This guy we talked about earlier, it doesn't matter that he's, his wife is taking care of him and, she's so dedicated. He doesn't need an LVAD. This is not the patient should have an LVAD. He needs a palliative care consult. What do you guys think about a patient maybe with Down syndrome? Let's say he's Down, but he has a really good family support. Functional Downs, like goes to work and goes to school. Family's been amazing. Well, initially we turned the Down syndrome kid down because he couldn't meet any of our criteria as far as cognition. We set the bar kind of low for cognition, but he couldn't meet anything. So what we did, we actually taught him about the VAD, and we tried to see if he could do it. he actually learned the VAD, and his family was willing to stay with him 24 hours a day or in 7 days a week. So we implanted this kid, and this kid has been alive for a year and a half. I don't want to jinx him, but he's never been back in the hospital. So it just depends on the family and, what you can do. After an LVAD surgery, the patient will not be able to do one of the following. Won't be able to swim. And the average 1-year survival for the country is around 81% for both arms of the LVAD patients. So heart failure patients have a high risk of morbidity and mortality. Treatment options are available, but selection is key. Hemodynamics can be useful in guiding therapy. I have more, but I didn't know how much you wanted me to do, but I don't know.
We're okay.
You're okay? Okay. So patient selection. So when you have these durable devices, you have to make sure you select the right person. Because if you do not, you will have a bunch of patients in the ICU or a bunch of deaths, okay? So we have different risk scores to try to help us choose who's at high risk and who's not. But the risk scores are not perfect. Intermax is our national registry that we use to determine, that we put in, so we know, the benchmarks. What's the survival rate of our patients? Do they have renal problems? So it's our national registry to kind of help us get a gauge of what the entire country is doing. But they've developed 7 clinical profiles of patients before they get VADs. So they have the number 1, the first profile is the patient in critical cardiogenic shock. So this is the patient who's been on inotropes, but now needs an Impella and just got intubated. So that's called the crashing and burning patient. 2 are the patients on inotropes, but maybe you have to increase the dose of inotropes. And 3 are your stable patients on inotropes, but maybe they're home, but they're stable. So what's the importance about knowing the Intermax group is that the Intermax group prior to implantation is associated with their survival. So if you tried to put a durable VAD, the HeartMate 2, or the Heartwear into a patient who's crashing and burning, their chances of not making it out of the hospital is over 30%, and this is known. So they're very expensive devices. It takes a lot, so we don't like to put these devices in people who are not going to do well. So the best thing to do is put the short-term devices in, see what happens, and move from there. Not only do the crashing and burnings have a high mortality, but they also stay in the hospital a longer period of time. So when you're selecting a VAD patient and you have people in clinic, you can't wait too long because the crashing and burning patients have a very, very poor survival. You don't want to implant people who are intellectually challenged and not able to learn. If they have family support, that's important, but they have to be able to learn the device because they can't die because they can't put the batteries in. So even with our Downs young man, he learned the device. You don't want to implant people with minimal support. And lastly, patients are really sicker than they appear. So what kind of questions do you guys have about LVADs? I can keep going. I don't know how much you want to know because it's now more into the chronic.
Yeah.
Yeah, because I think you want more acute.
Yeah.
Yeah. Yes.
How is ACLS different than LVAD?
That's a great question. So for ACLS, you should not do chest compressions because the inflow cannula or outflow cannula could dislodge and the patient would exsanguinate. But you can do ACLS protocol, all the meds. You can cardiovert, defibrillate. Do not disconnect anything. What's so good about how we train the hospital, everyone has a role. So we've trained the rapid response team to know what to do with the VAD. So you shouldn't have to do anything with the VAD. And the nurses where the VAD is located are all VAD trained. So only thing you have to do is run that code and make sure no one does chest compressions. But you don't have to fiddle around. But it should, you should say things. Is the device connected? Is the device working? So someone puts a stethoscope on and hear the hum. Things, basic things like that. But you should just run the code as usual. VFib, VTAC won't look the same. The patient will be awake and looking at you. The problem with them staying in VFib or VTAC for long periods of time is they're more likely to develop a clot in their right ventricle. So that's the problem. But it's not the same type of code at all. Watch there be a code today that's like a disaster. But typically it's not that kind of code.
So you do defibrillate them as soon as you can if they go in?
No, you're controlled. You make sure their INR is therapeutic. First of all, you call the VAD the VAD pager that's in every room, called the VAD coordinator pager. But you want to make sure their INR is therapeutic. If their INR is not therapeutic, you do not want to. You want to give them like 5,000 of heparin, but like that's why you would call the VAD coordinator. But you have time. They don't deteriorate like a normal patient does. Yes, yes, they do not deteriorate. Any other questions about VADs? Yes. So they're both continuous flow pumps, okay? They both will not have a pulse, but one's centrifugal, is circle, and one's linear. But as far as the survival, they're very similar. At one point, the HeartWare device, okay, the HeartWare device had an increased incidence of stroke. But they corrected that by making us make sure the blood pressures were controlled and to go to the higher dose of aspirin, 325, and now that's corrected. But the survival between those two are very similar. We do have the HeartMate 3 that's currently in clinical trial, but it's not FDA approved yet. I think we have like 12 patients with that device, which is a magnetically levitated device. Looks very similar to the HeartWare, but the problem with that, what did you say? I'm sorry.
Correct?
No. There's a pulse inside there's a washout period.
Okay.
Inside the speed goes up and then goes down. It's a little tiny washout of the pump, but you won't feel it. Yeah, and that's a decreased clot. Yeah, but we have that device too. I think there's like 12 patients with the HeartMate 3. So you'll see these patients around. Okay. All right, thank you.